Welcome, everyone, to the Special Populations Core 2022 seminar series of the New Jersey Alliance for Clinical and Translational Science. Thank you for joining us today. We're very excited to have Professor Chelsea Shover of the UCLA School of Medicine with us to present epidemiological surveillance of fatal overdose in the U.S. using pooled medical examiner records. Before we jump in, if you have any questions, feel free to unmute and ask throughout the presentation. Happy to have this be an interactive conversation. And to get us started, I'm going to turn it over to the director of the Center for Health Services Research here at Rutgers and lead of the Integrating Special Populations Core, Dr. Stephen Crystal, to introduce Professor Shover. So Steve, over to you.
Thank you. It's a pleasure. And this is really, I think you'll find this is really fascinating work. Dr. Shover is an epidemiologist and assistant professor in residence at UCLA in the Division of General Internal Medicine and Health Services Research, a division that has a very impressive history of doing important health services research. She completed her PhD in epidemiology at UCLA and a postdoc in psychiatry and behavioral sciences at Stanford. Her research focuses on addiction, infectious disease, and their shared social and structural risk factors. She's also served as an epidemiologist in government and nonprofit positions, most recently as supervising epidemiologist for the LA County Department of Health, Public Health's COVID-19 response in homeless shelters and encampment. So right in the front lines of some of the most difficult social problems that we have. She's supported by grants from NIDA. Her current projects include methods to rapidly use available overdose data to inform healthcare, public health policy, as well as community-based implementation of harm reduction strategies. So I was very impressed to see this work shared at the VAX opioid VA cohort study opioid work group, and it always seems amazing to me that if we took 100,000 deaths a year seriously as a public health crisis, we would certainly want to be digging a little bit more into the underlying data and the weaknesses and limitations of those data. So it's important that people are doing this work. There's not enough of it to this day. So with that, I'm very happy to turn it over to you, Chelsea.
Well, thank you for that lovely introduction, and very happy to be here. I see we have a manageable sized group, and I'm happy to take questions throughout. You can just unmute and ask. If you'd rather put it in the chat, go ahead. It might take me a minute to see it, but definitely feel free to unmute and ask questions throughout. And I know a couple of my staff, Caitlin and Ruby, are also here. So
great.
Let's go. Great. All right, let me just get it to, yeah, there we go. Next slide. Okay, so, as Dr. Crystal mentioned, we have a massive annual toll of overdose death. This is a graph that if you're working in drug-related research, you've probably seen, but I want to point out a few specific things about it that'll anchor our conversation today. So this is the most up-to-date data as of, I guess, a month ago. It might be a little bit newer now, but nationally from the CDC, the provisional overdose mortality data. And this is broken down by classes of drugs. And these are based on the ICD-10 codes. So that's International Classification of Diseases, 10th edition. Those are were primarily introduced to use for billing rather than, say, public health monitoring or their diagnosis codes. And so they do group together a lot of things that might be not very similar. So this
Chelsea, just one of the many technical questions that come up with these data.
Sure.
You're presenting them up to the most available date at which I guess they release provisional data, which looks like it's about 4 months into 2022?
Yeah, so this is from, I pulled this in October, and so they released it September 4th, and this is provisional data through April 2022.
Yeah, so when they release data like this and you see what, maybe looks like a recent trend or recent blip, are those data complete enough to, for example, for us to say that, well, there seems to be some flattening or potentially a little bit of decline going on at the moment?
Yeah, so I think I feel pretty confident that they're complete, or that they're complete enough, right? They are provisional, they're not entirely done. I know I've worked with, I'm not sure what the breakdown of who's on the call, but if there are, folks who are just, getting into this and want a good data source, CDC Wonder is a really great tool because it's wide-ranging online databases for epidemiological research. And you're able to now, as of last year or this past year, you're now able to get provisional data at the state level and broken down by different demographics. And I've done a few projects with those where I download the data and then download the same query a few months later. And the difference is really small in terms of nationally, it's like a few hundred deaths off. So I feel pretty comfortable with these as saying, these are, yes, they're provisional, but they're pretty complete. I think as far as when we're looking at this decrease you see in the last few months available for synthetic opioids, that's not enough data for me to say that's a long-term trend or that's
Right.
a true decrease. But I feel reasonably confident that when we get the final numbers, we will see a dip there. It's just a question of, does it go back up?
Right. Okay. Very, very interesting. And of course, everybody would like to get closer to real time. So it's
Yeah,
one of
exactly. Yeah, and it's interesting. I started doing the work that I'm about to talk about. So this is all CDC's data. This is I have nothing to do with this, but I use it just like many other researchers. And I started doing the work that I'm about to show you in April 2020 because at that time the CDC data lag was like 18 months.
Yeah.
And now it's now and the provisional data only included at that time 29 states, and it did not include California.
Right.
Which is where I'm based and where I do a lot of my work. So I had initially started this as kind of response to the CDC data being very delayed.
Right.
Now it's getting a little better, but there's some other issues that I'll dig into. So these are all based on ICD-10 codes. This brown line is synthetic opioids other than methadone. That's mostly fentanyl and fentanyl analogs, but it also includes, well, I'll show you on the next slide what else it has. Then this gray line is psychostimulants with abuse potential. That is mostly methamphetamine, but also MDMA, Adderall, Ritalin, and then cocaine. Cocaine is cocaine. That's one that it's like, okay, that number only means one thing. And then methadone has its own code, and then natural and semi-synthetic opioids. That's predominantly the green line here. That's mostly prescription opioids. Of course, fentanyl is something that can be prescribed and is prescribed, especially for cancer pain and palliative care. But primarily when we're looking at this brown line, this is mostly illicitly manufactured fentanyl.
Great. Okay. And just as as an indicator, because you asked something about the kind of mix of people that are that are attending today. It's a mix of people, but several are people who are very much into the weeds on overdose data, mostly from healthcare claims, but also from other sources. So Peter, Jim, Sharon, Hillary, all are among our colleagues who have really tried to dig into the what is going on with overdoses. So don't be afraid of digging into the important questions about how we're measuring things.
Sure, great. Okay. Wonderful. So these are just some examples of things that the ICD-10 system includes together. It's interesting. I've talked with one of the main epidemiologists in the CDC who works on this data reporting, and it is really amazing what they've been able to do just in the last 2 years of speeding this up. But one thing that I was surprised to learn was that, ICD-10 codes do get more specific. So for other synthetic opioids besides methadone, or you have T40.4. There are ICD-10 codes that would actually specify fentanyl specifically, but that's adding another digit. And the CDC does not release that data. And so it's basically, you can't get access at a national level to data that really breaks it down by specific drug. And so the classes that I'm concerned about are, T40.4, that's fentanyl and fentanyl analogs, which are driving much of the fatal overdose in this country. But then it also includes buprenorphine, which, is a medication used to treat opioid use disorder and is very rarely involved in fatal overdose, which I'll show you in our medical examiner data. But it's all together. And so if one hypothetically wanted to understand, say, the impact, and I'm saying this hypothetically because this is an analysis that I worked on and I'm working on getting published, is like, did the change prescribing guidelines around buprenorphine and methadone change, lead to any kind of change in overdoses involving those drugs? And, Nora Volkow from NIDA came out with a pretty persuasive explanation for methadone because it has its own code, but for buprenorphine, you can't do it with the CDC data. We can do it with ours though, which is nice.
Does CDC, I know CDC, and I know CDC has some specialized data sets, like what is it, the National Violent Death Reporting System, and do they have more granular data in any of those systems?
Not to my knowledge. And more granular in the sense of like going farther down out to more decimal points in ICD, I don't think so.
Yeah, okay.
Because that's kind of what I was asking about was, they're starting up. I've heard that they're planning to restart the program where you can go to a specific CDC site. I know there's one in Atlanta, there's a few others around the country, and there's data you can access there that's more granular in some ways, but like not in that way, which is the main thing that I'm interested in here.
Right, okay.
So basically you can't use the CDC's data to look at polysubstance use, which I usually define as 2 or more substances within a category. So for example, if you wanted to look at fentanyl plus carfentanil, you can't do that with CDC data. You can look at fentanyl and cocaine. I mean, if you just assume that T40.4 is basically all fentanyl. You could look at cocaine and heroin because they each have their own code, but you can't look at things within a category like you can't look at methamphetamine and MDMA because it's all the same code. And so these codes also aren't as specific enough to track emerging drugs, which is another big interest of ours. Okay, sorry. There we go. But literal text medical examiners records are a lot more specific. So when I say literal text, basically we're taking the information that gets on the death certificate, which typically is up to 4 lines of cause of death, plus contributing factors, and this will just be written out. So here are just some examples of what cause of death can look like in the setting of polysubstance use. So cocaine, fentanyl, acetylfentanyl, and dispropionyl fentanyl. I never know how to say these. So I know 4-AMP is a precursor, but the point of this example is that if you looked at this in CDC data, you'd see T40.5 and T40.4, but that kind of obscures the fact that it includes both fentanyl and a fentanyl analog, acetylfentanyl. This one, hydrocodone, T40.2, atizolam, that's a novel. It's not really a benzodiazepine, but we basically treat it like it is. I think they're called thienzodiazepine, but it's very similar. Isotonitazine and flualprazolam. So isotonitazine is a novel synthetic opioid. Flualprazolam is a novel designer benzo. And so this would just get classified probably as, prescription opioids, synthetic opioids, and benzodiazepines. But really, this is interesting because this cause of death includes a prescription drug, hydrocodone, that's been around for a long time, and 3 emerging, novel psychoactive substances that are just really becoming part of the illicit drug supply in the last couple of years. And then this last one is just an example of this you can also sort of see with CDC data, but you can, with the literal text medical examiner's data, it makes it very simple to be able to see causes of death that involve drugs and also other conditions. And for methamphetamine, this is particularly important because, methamphetamine can't, using enough methamphetamine at one time for the right person can result in death, usually through like immediate cardiac cause or an intracerebral hemorrhage. But a lot of the methamphetamine related deaths we see, where it's only meth on board, not meth plus opioid, do tend to be meth with an underlying comorbidity, usually cardiovascular.
So just to clarify,
Yeah.
For people who haven't worked with medical examiner records, these medical examiner records are from the death certificate or from other data that are not in the death certificate?
These are all from the death certificate.
Okay. And death certificates, for those who, can be confusing for those who haven't worked with them. Could you sort of briefly orient people to the way that death certificates have the multiple causes of death, the multiple cause of death fields, underlying cause, immediate cause, et cetera? Yeah,
so different jurisdictions do it differently. But the main, the general template is it will include the death certificate will include someone's name, basic demographics like age, sex, race, ethnicity, and then it will just have cause of death, and it's like cause A, cause B, cause C, cause D. That's filled out by either the medical examiner or the physician who's certifying the death. In the vast majority, if not all jurisdictions, drug overdose fatalities are cases that are referred to the coroner or medical examiner. Those are also 2 distinctions. The medical examiner is going to be someone with an MD training background. A coroner might have that degree, or they might have no degree, depending on where it is. And then all these determinations are made based on a combination of exam, postmortem toxicology, evidence at the scene, and maybe even interviews with family. And it varies. So some people will have a cause of death written out without any kind of further examination, whereas others will have pretty extensive testing, autopsy, postmortem testing. And the contributing factors is another field. I have also, from some places, been able to get toxicology results, which is separate, so basically, if they do toxicology on someone who's died, they might come back with a lot of things, but some of those things might not be implicated in causing death. So for example, in our cause of death, we don't have any cannabis except for in terms of overdose. We do have it where it's driving while under the influence of cannabis or something like that. But there's plenty of people who have cannabis on toxicology, and there's pretty well accepted now that just, having that on your THC or CBD or any other cannabinoid in your tox screen doesn't necessarily mean it contributed to death. It also means that some people drugs were obviously not the cause of death. It's clearly a firearms death. They'll still have tox results that might be positive for something, but that's not going to end up on the death certificate.
And how do you deal with the sequence? There's some coding rules about going from the most immediate to the underlying.
Mm-hmm. Yeah, because I'm pooling so many different jurisdictions, and because they do it differently, I just take it all together, which I found some examples in literature of researchers doing it that way. So that's what I do, because I'm really interested at a population level, and I'm looking at this more as drug supply surveillance and large population or population level trends, rather than trying to figure out what an individual or small group of people died from.
Right, right. So you don't concern yourself with which position it's in.
Right, correct.
They're all multiple
Also, some
causes.
places will only give me one, like it will
Yeah.
just be cause. Like,
Right,
okay.
right. Okay.
But I've never seen more than 4, and that seems to be pretty typical. You know, and the things they call them are different. Some will say underlying, but most places, in my experience, have just been A, B, C, D.
Great.
Okay. So basically what we did to get a data set of all these literal text medical examiner records, and we have just under 700,000 now, spanning from 2012 through early 2022, different periods of time for different jurisdictions. Some places, I'll show you in a second, gave us all deaths, some only drug-related deaths. So it's really a messy data set in the sense that you have to, when I'm working with it, I have to be like quite clear about what I'm including and not including, but the actual number of records we have is very large. So basically I have a team of research staff. We created a directory of contact information, email, phone for the 10 largest jurisdictions in each state that have a medical examiner, plus the state medical examiner. And then individually reached out to them and followed up. And my team has been great about, you know, when someone says like, try us again in 6 months, like taking them at their word and actually emailing back and requesting it. And a lot of places have given us data that way. We ask for a standard list of variables in like a comma separated values file, but we'll take anything. Some places send us PDFs, and then, you know, the research team has to transcribe them or convert them. Some send us variables that we didn't ask for. And many of the things that we're interested in, you know, I'm really interested in homelessness status, especially as the contribution to overdose mortality, because that's something else. That's a homelessness and incarceration are 2 things you can't measure in CDC death data, at least not with the national data set. So those are 2 things that are of a lot of interest to me, but a lot of medical examiners don't measure those either. And so we clean the data. This is a really time-intensive process, and it's ongoing as we add new jurisdictions. And I think the one key thing as far as collaboration is we do offer for medical examiners or coroners who want to join in publishing, you know, who want to contribute to papers, even if that's a pretty minor, like, you know, they're giving us the data, that's really important. But then if they have any kind of intellectual contribution also, which is very helpful because I'm not a toxicologist, we offer, you know, them the chance for co-authoring. And we've had at least 1 or 2 take us up on that. And that's been really good, because when we have to sort of try to explain, like, what is the reason, what might be the reasons for this, it's very helpful to have them on board. Even, you know, even when I'm working with other physicians that I usually work with, it's very helpful to specifically have like medical examiners and folks who have done maybe a toxicology fellowship. So our current data set covers about 20% of the US population, and this is all by asking. A few places do have these publicly available, you know, Chicago, the Dallas-Fort Worth area, just has, you know, in San Diego, you can just like download a spreadsheet of medical examiner cases. But most of them we ask, and it's, we got all deaths from the state of Minnesota. So that includes deaths that were not referred to the medical examiner. So that includes a lot of deaths that just, you know, medical examiners typically have jurisdiction over deaths that are like homicide, suicide, overdose, traumatic injuries, unwitnessed deaths, particularly in, you know, people that weren't expected to die. I think here in LA, I think it's also people who die within 24 hours of being admitted to the hospital, because otherwise it's like the hospital doctor can just certify what happened. So Minnesota, we have everything from 2016 to 2021. Most places we have just drug-related deaths. And that's a determination that the medical examiners make, and some do it by sending us everything with a positive toxicology, which means we have to go through and like take out ones that are like, oh, like gunshot wound. Also, they took buprenorphine. It's like, well, the buprenorphine has something to do with that. And then a few like Los Angeles and a couple others in California, Texas, and I guess, oh yeah, here, Chicago. We just have all medical examiner cases. So that's, I think that can be interesting too, to sort of look at other, I can imagine other avenues of research where we're looking at other, violent deaths, although the CDC's violent death reporting is pretty good, but like if we want to get really specific about it, this is helpful for that. So for our initial classification, the first thing we do, so one of my colleagues, David Goodman-Meza, developed some natural language processing algorithms to classify these records by substance involvement. We initially classified 35,000 manually, not like one by one, but with manual keyword matching and checking for misspellings and other terms, and did use that to build and train models to be able to classify them. So we found that the algorithms perform very well for the opioids, for cocaine and methamphetamine and alcohol. They didn't do as well for benzos, but I think that's just an issue of sample size. And as we continue validating more of our data set with this manual classification, then we'll be able to do a better job of improving algorithms for less common substances. And then after that, the classification is, by specific drugs. So for the less common things, it's that's how we do that. So this has allowed us, now I'm just going to show you some of the things we've learned from these data. This is a modification of, or this is like a draft version of a chart that we published in the Lancet Commission on the opioid overdose crisis, showing the differences in drug combinations by jurisdiction. These are all for 2020, with the green is heroin, the pink's cocaine, blue's methamphetamine, and then the brownish yellow is fentanyl and fentanyl analogs. And these are proportional Venn diagrams. The thing with Venn diagrams, these are not like perfect exact representations that overlap. Like those are too messy to look at, but these are like approximations of what they generally look like. And the big things you can see are that comparing Chicago to Cook County, Illinois, is the county where Chicago is, comparing that to Los Angeles County, you see that there's a ton of overlap with heroin and fentanyl in Chicago, where almost all heroin-related deaths involve fentanyl. But in Los Angeles, that's not the case. There's very little overlap. And there's a lot more overlap in Los Angeles between fentanyl and stimulants like cocaine or meth. I guess Chicago does have a lot of cocaine overlap, but they just don't have very much meth, at least in 2020. And Connecticut looks sort of more similar to Chicago. And then you have Dallas. I don't know what's going on here, where it's just not very much overlap at all. And so this isn't accounting for like other drugs that might be involved, but just these as sort of the four most common, what I think of as like street drugs, how these Venn diagrams look really different depending on location. And we know that polysubstance use or polysubstance overdoses are increasing. But what that actually looks like on the ground varies a lot depending on where you are. Okay, and so this is from another paper we published on xylazine, which is a veterinary tranquilizer that has been a part of the Philadelphia heroin market for a while. It started becoming popular to use with heroin in Puerto Rico, and then in Philadelphia, and has gradually spread more commonly around more of the United States. And we found that it showed up. And so this type of graph is basically showing the percentage of deaths that involved these different combinations. And the color is just like how many drugs are involved. So in Connecticut, the most common combination was to have xylazine and fentanyl. And I think the other thing that's important to know is like you can look across the whole way and you can see that we were just comparing jurisdictions that had a lot of xylazine. And it basically showed up with fentanyl all the time. So, and then, if there were in other ones, these like the yellow dots indicate that there were 4 drugs involved. And so you can see that there's some differences there across jurisdictions where, it's less common to have 4 drugs than have 2 drugs. That shouldn't be very surprising. But in Connecticut and Philadelphia, this combination of xylazine, fentanyl, heroin, and cocaine is here. But then in Jefferson, Alabama, you've got xylazine, fentanyl, methamphetamine, and cocaine. And in Chicago, it's xylazine, fentanyl, heroin, and benzos. And so this is just like a different graphical way to represent the overlap and the combinations. Okay, so for novel psychoactive substances, this is kind of the other. So polysubstance use or polysubstance overdose is one main use case I have for this data that I'm interested in, and the other is identifying the prevalence of novel psychoactive substances. A lot of, the main surveillance currently in the US around novel psychoactive substances, there's 2 groups that work together. There's, NPS Discovery and NDEWS, which is National Drug Early Warning System. They both do great work, and especially in like sounding an alert when a new substance is identified. They don't tend to, NDWS is starting to, but they historically haven't done as much with, well, how common is this thing? The DEA puts out publications too that'll say, oh, this drug was identified in this census region. It's like, okay, like that's great, but was it there one time, 100 times? Is this something that people really need to be looking out for? Do we need to change our public health response? In the case of xylazine, the concern is that 1, it's a sedative because it's a veterinary tranquilizer, and 2, it causes soft tissue infections. And so when xylazine's in your drug market, as it is in Philadelphia, and I don't have data from New Jersey, but I suspect there's a lot in New Jersey too. You need to be thinking about that for wound care and also for overdose response, because naloxone will still work on the opioids that are on board. But if you have someone who's very sedated and not responding to naloxone, it might be that they've got xylazine on board, and then you need to do the supportive care to bring them back. It also puts people at risk if they're, out in public and they're just very sedated. They're at risk for all kinds of things, of course, like robbery, assault, etc. So the case definitions for our novel psychoactive substances work. We wanted to look at drug-related deaths. We looked at between 2019, starting at the beginning of 2019 through most recently available data, which varied between sometime in 2021 and sometime in 2022, depending on the data set. Most have through the end of 21. So at least one drug listed in the cause of death or contributing factor. And for the novel psychoactive substances, I'll get to a list of some of them in a minute, but just one of the 38 substances that were called out in the European Monitoring Center's 2021 report. So it's not all of the novel psychoactive substances, there are thousands, but just the ones that they had highlighted as like, these are drugs of concern. And I had initially done this as an analysis to sort of show that, or to sort of examine whether can you use these literal text medical examiner data to track the spread of novel drugs, or are they too rare and don't show up? But yeah, that's what we did. Oh, I'm sorry, we stopped in June 2021, right, to have the most data. So January 2019 to June 2021, 17 jurisdictions. This included a total of 49,000 roughly deaths. Here are the novel psychoactive substances that were found in at least one jurisdiction. So I've got the name, the count, the type of drug it is, and where it was found. I'm happy to share these slides after. I know this is like a lot of terminology or just a lot of words on page, which, so acetylfentanyl, that's not that new. So I'm not surprised to see that that's the most common one that showed up and that it showed up in a lot of places. Atizolam and fluoroprazolam, those are a little newer. Kratom metragenine. So this is somewhat controversial. It's a plant. It's been used for a long time in different parts of the world. It's new-ish in like the US context, or at least becoming like more popular, right? Like it's been here, but it's new for a lot of contexts here. And I think the best, I feel pretty confident saying that the best evidence suggests that does not play a causal role in overdose, but the case of metragenine kind of illustrates an issue you get with novel psychoactive substances where, since they're new, different, experts may disagree on how relevant they are in causing death. I have an interesting example of that with xylazine too. But with kratom and metragenine, I spend a lot of time talking with folks who really study it, and just thinking about the mechanism and the way that it might play is like unlikely, but it's new, and people, when they find it, they put it on, even though it does, in my data, it's always showing up with a bunch of other stuff. So it's like, oh, fentanyl and also metragenine. And it's like, well, this person probably would have died without the metragenine too. But yeah, carfentanil, bromorphine.
Is carfentanil declining?
I don't know.
You don't have,
look.
Yeah, you probably don't have data from Ohio. I think that's where it really peaked.
Yeah, I have a little bit. Yeah, so sorry, Lorain County is in Ohio. Summit County, Ohio. I don't know that I have anything on there for them. Yeah, I don't know. I'd have to look, I'd have to like graph that out. But that's also something that I've heard, especially at like NPS conferences. But yes, lots of carfentanil in Ohio and not a lot of other places. Although interestingly, I recently learned that the fentanyl test strips that you use for either like checking drugs or you could use for urine testing, they actually don't pick up carfentanil. I don't think that's an issue with postmortem toxicology, but just, thinking about other ways we might use to do surveillance, that's kind of an issue. They pick up a lot of other fentanyl analogs, but not carfentanil, which I just learned that last week and I was very surprised.
Yeah.
Okay. And then plenty of these, only show up once or twice. Like, all right, well, we'll see, we'll check this again in a year or so and see where it goes. But my story about xylazine is that that's probably the drug I've talked to the most medical examiners about. And I found that there's I met a few who just flat out say like, this is not important in causing death. And so we do not put it on the death certificate. So that was very surprising to hear that like some jurisdictions or states just don't do it. We test for it, we record when it's there, but we don't put it on the death certificate because we think it's just an additive. It's like, well, like that's an issue of these newer, xylazine's not a new drug, but its relevance in the illicit drug supply is new. And, while I guess sort of the science is unsettled, and also, the testing we're doing is not quantifying, a lot of postmortem testing isn't doing quantification. So it is true that a very small amount of xylazine might not be relevant, but a large amount might. And if we're only doing qualitative testing for presence and absence, we don't necessarily know. So the prevalence of NPS across different jurisdictions, it was highest in Lorain County, Ohio, which is, not a large sample of deaths, but a lot of them involve novel psychoactive substances. And that is mainly the fentanyl analogs, like acetylfentanyl, carfentanyl's up there. All the way down to, Los Angeles, where I am, only 1% of drug-related deaths involved in NPS. So that part of that's, an artifact of testing. We'll see jurisdictions that know to look for something, we'll start looking for it. In the example of xylazine, Philadelphia, state of Connecticut, do universal screening on suspected drug deaths. And so they're going to catch it a lot more than, say, Los Angeles, where they only do the extra testing that would pick up xylazine if they don't have a cause of death from their standard lab testing. And so because it always shows up with fentanyl so far, they've got fentanyl documented, and so there's no need to send out for new testing. So that's, these are all misclassification things. And getting a good understanding, that's been one of the challenges and opportunities of this project, is getting a good understanding of how different jurisdictions do this differently. For combinations, as far as just grouping all the NPS together, which, as I showed you, it's a pretty diverse group of drugs, but just to sort of see where they're showing up. And the orange is with, we're looking at fentanyl, cocaine, heroin, and methamphetamine. Again, most common street drugs involved in death. And the vast majority of deaths involving NPS also involve fentanyl. So they're just showing up together. Of course, death certificate can't tell you whether someone took two different things. One was fentanyl and one was, an NPS. Or if someone took a product that contained both. But I think it's suggestive. And, pretty commonly involved with heroin, more rare with cocaine, and like pretty rare with methamphetamine, given how the methamphetamine is. So I see a question. Not being familiar with all this, is a comprehensive tox screen done on, say, a traffic fatality who might have wandered into traffic while intoxicated? That's a good question, and it varies by jurisdiction. Most of the time, no. But some places do. So yeah, that's another limitation of both this data and also, so the CDC data that they get to track like overdose deaths. That's all it's from counties aggregated up to the state and then aggregated up nationally. So it's based on this information. But yeah, some places do routine talks on everybody, but a lot don't, especially in, the budget realities for medical examiners are, I'm not surprised because I work in public health where like budgets are always a problem, but it seems like it's maybe worse for medical examiners. So, and the send out tests do cost money. So it also depends if they have an in-house
lab. Have you been able to compare these data to on the drugs found among overdose decedents to the NIFLS data on the drugs found in street seizures?
Yeah, I haven't done that directly, but I do read the NIFLS data, and I've been sort of thinking about how to bring that together, because yeah, I think that's both getting at it, right? Like when you see in NIFLS that like, oh, there's an increase in the number of cocaine seizures that contain fentanyl, that would lend credence to like, oh, they're actually, this is actually one product that has both. So yeah, that's kind of in the long run I'd like to do. One thing is
you haven't tackled trying to get more granular data from NIFLS than they make available.
I mean, I've tried, I've not succeeded, so I've kind of given up on that avenue. But
well, that's an important data point. We
absolutely. Do you have it?
We discovered this early on, and then we had various correspondence with them, which was sort of not very helpful, and it didn't seem like they really had an interest in having their data used for kind of deeper research than the statistics that the rather broad statistics that they put out.
Mm-hmm.
I was never clear on whether they just didn't appreciate the potential public health significance, or if they were concerned that because their constituency is the labs that provide them the data. So if you start getting granular, I think you're sort of at risk of seeing that some labs are doing a lot better job at screening for certain substances than others, and perhaps that's a sensitive topic, but it's very unfortunate.
Yeah, it is, and that's pretty in line with my experience of requesting data from NIFLS or from DEA that has things like with drug seizure data. It's not primarily a public health mission,
right?
And so
exactly,
yeah. So yeah, very interested. No progress yet. I do try every time I have an opportunity. But we'll see. Maybe someday. But the issue about labs, that's interesting you bring up, because the medical examiner data makes that very clear. And that doesn't, I think it's mostly a resourcing thing and priorities thing. That, for example, Chicago has phenomenal postmortem drug testing. I don't know the ins and out of it because they actually make theirs just publicly available. Anyone can download it. But one, I think the Midwest is actually, that area of the Midwest is actually a spot where a lot of drugs emerge, but also their testing is just better and more comprehensive. And so they're going to pick it up when it does emerge there. So yeah, you can kind of see that gradation. And I mean, I've also, there's one jurisdiction I don't even include in here because we asked for drug related data and they just sent us back a list of 50 deaths that just said drug overdose. And I was like, okay,
just
but like,
do a little time check so that we make sure.
yes,
that we leave time
I'm
for everybody's questions.
basically done. So I can take questions. Limitations, I've covered most of these. Might not generalize to the rest of the US. We talked about testing or not testing, and causality can be hard to determine. Here are some of the papers from this project. I want to thank all of my staff and collaborators who have worked on this, many students involved, and that's been very cool. For folks who might be interested in collaborating, I'm working on getting this process a little bit faster. It's a little slow now, but you know, we have a few out there in the world where someone comes up with a hypothesis and a basic analysis plan, we pre-register it, and then I send over the CSV, because this is all, none of this is public or personal health information because it's all for people who are deceased. But I mean, I'm not identifying information, but basically it's very easy to just transmit via email. It's all non-identified. And that is the end of my presentation. So I can take questions.
Great, let's open it up. Everybody's just collecting their thoughts, but I think people will have questions.
I do want to note though, I don't have any, I double checked, I don't have any data from New Jersey. So if anyone knows how to make some connections in New Jersey, that's one area I have not.
Peter, do you have any sense about the state medical examiner? I think they do a fair amount of testing in the state lab and then like the rest in county labs.
Yeah, I'm not sure how it breaks out. I know that there's like a handful of major labs across the state, and some of them are like within counties that cover multiple counties, but we've tried to get more detailed mortality data and it really hasn't, we haven't been able to make any headway on that, although we haven't tried in a while.
Mm-hmm.
But it seems like because it's managed by a few different organizations, it would be really difficult to get something statewide. Yeah,
well, I don't even have any counties in New Jersey, so I don't know. I mean, we can certainly go back and revisit because it's just fine. I mean, there's other states where I also don't have anything. I just like, oh, I'm giving a talk at Rutgers. I can like talk about how I don't have any data from New Jersey. I don't have much from New York either. Maybe none actually. But yeah, it is really, that's the thing, is like, it's all like very fragmented, and there's a few places that the state will just be like, yes, we're willing to give it to you. Or, and it's obviously you have to do a data request process, but they're usually not too bad. But yeah, a lot of will be like, well, why don't you go to the county? And it's like, okay. Yeah.
Do you know where the NIFLS data comes from for each state? Is it from like one major lab, or are they able to?
They have, my understanding is that they have surveillance labs where, so like, if I'm like, a law enforcement person, I was like, oh, I have this weird drug, I send it to, and I think there's like multiple ones in many states, but I don't really know. I just know that every time I've asked for something, they just send me their report. And I'm like, I know, but it's really old. Some question in the chat. Any good information on ISO that has been in the news of late? I haven't really been following the news, but I do know that like the overall prevalence of ISO in drug mortality has really declined. If you go to a toxicology conference, they will say that's because the DEA scheduled nitazines. I'm not sure that I totally think that's not necessarily what I would attribute it to, but that could be part of it. It also might be the case of, sometimes we have outbreaks of novel synthetic drugs where it's like one lab, and that, like in England, they had a carfentanil outbreak in 2017 that was limited by the fact it was just one lab. And then when that lab got shut down, no more carfentanil. I think it's possible that the supply chain for ISO might have been small like that. And so maybe, enforcement action or just for some reason moving on to something else may have been enough. It also doesn't sound that pleasant of a drug to use. I mean, just from reading Reddit, I don't know. So it could also just be that, like, one factor might be the demand decrease. I don't know. So it says, why is fentanyl so abundant? And yes, fentanyl is very cheap to produce. Unlike, say, heroin, where you need a poppy field, you just need a lab. So yeah, fentanyl is very cheap. It's very strong. And that means that a smaller amount you can sell for a lot more to get, the same effects. What big organizations play in all of this? Sorry, can you say, Allison Lopez, thank you for your question, but can you say a little more? What do you mean big organizations? Oh yes, the RAND report on fentanyl is phenomenal. Highly recommend it. Yeah.
Looks like Allison has left, but what the question made me think of was sort of, and that there's a sort of few different ways to ask this. Like, number one, why isn't the CDC doing this? Number two, why isn't the CDC supporting what you do? Or is it, to a degree, an issue of you're having to do, sort of make data available for research that the CDC doesn't make available for research at a more granular level, even though they have it? Because there's a little bit of a conflict between their role of putting out only information that is they consider to be some level of rigor or completeness versus letting the research community make the best use they can of what's being reported from the MEs.
Yeah, no, that's an interesting question. I mean, I will say the reason that the CDC and the reason no one is paying you this is I have barely tried to apply for funding for this particular project. I do have funding for similar projects, like focused on Los Angeles. And now this is kind of, in the next 6 months, something I'm planning to apply to get more sustained funding. I had initially started doing this just because I was working with my mentor, Keith Humphreys, at Stanford. And we had both sort of said, like, I wonder when fentanyl will get to the West Coast in a big way. Because we knew of cases, and like usually like one off or a few off, and started doing it systematically that way.
This is a huge and really interesting question that I always wondered about. And I think there was, there were like some simplistic explanations that were out there that probably didn't tell people as much as they thought. Like, well, it's black tar heroin, so
yeah. I mean, it definitely is true that, like, people don't really enjoy, like, on average, people don't want to mix fentanyl into black tar, and people who use black tar maybe don't. But like, that's not the only thing, but that's probably part of it. But anyway,
so you're pretty close to those front lines. What are you seeing most recently in California and the West Coast in general?
Yeah. I mean, the biggest thing here right now in terms of causing death is counterfeit pills. We did a paper on it with the CDC data about youth overdose, finding like huge increase with fentanyl. And then on the ground, you see, like, talking with schools and stuff, you see it's like counterfeit oxys, counterfeit Percocets, that, are actually entirely or mostly fentanyl. And so when you have people buying them who think there's something, even you see this with like benzos too, with like fake Xanax that actually has fentanyl in it. So that's kind of the biggest thing right now. The other big thing, especially with people experiencing homelessness, is fentanyl and methamphetamine. I am increasingly thinking that's mostly co-use, where people know they're using both. You use fentanyl for a long time, and you start needing something to help you stay awake. And methamphetamine is also synthetic and extremely cheap to make and very available. And, I guess the phenomenon here we're seeing is that like people, a lot of people in the West Coast and probably other places have switched from injecting fentanyl to smoking it, which is, that's helpful in terms of reducing the number of injections, reducing opportunities for bloodborne viruses, and injection-related infections. It's not clear to me, and I say this based on like talking with physicians who would actually know about this. It's not clear to me that that's actually protective for overdose. I see how it could be, but I don't know that it really is. But we see like a common way people use is they'll inject methamphetamine but smoke fentanyl. And so that's like increasingly what we see out here. So yeah, those are kind of
so many unanswered questions in your last couple minutes. Let me just kind of invite you to say any thoughts that you have about big picture, the big picture. What can we do with these kind of data? What do these kind of data suggest to us about what more effective policy solutions would be to the whole problem of the huge number of deaths?
Yeah. I mean, it multi-pronged. I think number one for reducing deaths, I think about not primary prevention, but like, I guess it's probably by that point tertiary, but like preventing people from dying, right, is like Narcan. And then slightly upstream of that is drug testing, options for like a medical safe supply for people who maybe have been living with a heroin use disorder or fentanyl use disorder for a long time, safer for that to be prescribed. I don't think that should be widely available and easy to get, but like for people who are already having a substance use disorder, I think that's a good option.
Right.
I think for the vast majority of people though, who die or use fentanyl incidentally, we want things like making fentanyl test strips very easy to access, improving education about how to use them. So yeah, it's like number one, Narcan, number two, knowing what's in your drug or getting a regulated supply. And then upstream of that is like all the treatment and prevention.
Well, when you sit in LA, which is why, I think it's really interesting to, to think about, and you're sitting in a place that still hasn't been swamped with fentanyl. So like, how could we, if we wanted to just think more broadly, I mean, just as, for example, as a little bit of thought experiment, is the federal government, by continuing its traditional heroin interdiction efforts, actually driving shifts to fentanyl and causing deaths? And more broadly, any thoughts you want to share before we close, which we'll have to do on, is there anything that should be considered at any level of government or the community to sort of try to keep this potential flood of fentanyl from overwhelming the West Coast?
That's a great question. I think you can make a good argument for what you said. And I would put it out and say we are swamped, not in terms of our rates. Our rates are still lower compared to the Midwest, the East Coast. But in terms of absolute number of overdoses, like yes, Los Angeles is the largest county in the country. It also had the largest number of overdoses for the last few years. And so, it's sort of how do you want to measure it, sort of thing. But yeah, I mean, I think that decriminalization and focusing interdiction efforts on the things that are actually really harmful, like counterfeit pills,
right,
is
exactly.
super important. Yeah,
exactly. I mean, this, just obvious questions like,
yeah.
because not, I mean, people probably in law enforcement probably understand this to some degree, but their system tends to go on autopilot, so they do what they've done before.
Yeah, it's been interesting. I know we've had a lot of large fentanyl seizures in LA recently, and I've like talked with reporters about it, and you know, it's like, yes, it's well, so on the one hand, it's like it's great if you take a bunch of fake pills off the street, but it's so cheap and easy to make, there's going to be more. So we really need all these other interventions I talked about.
Yeah.
So yeah.
Well, awesome. Well, that's
Great.
wonderful. And I'm sorry that we have to close, but
Great.
thanks everybody for coming, and thanks you so much for sharing this
Yeah.
important work.
Great. Thanks for having me.